Our first speaker is
Mute on.
Who's worked in Healthcare Improvement Scotland for over a decade.
Mute on.
She currently leads the measurement and monitoring of safety and effective care programs. Jo is going to speak to us about how Scotland became involved in the Measuring and Monitoring of Safety Framework initiative and introduce us to the work of the initial pilot sites in Scotland of NHS Borders and Tayside. Our next two speakers will be Alison McGurk and Morag McRae. Alison is the clinical team manager in adult mental health and has been involved in the testing of the measurement and monitoring of safety framework along with colleagues in NHS Tayside. Specifically, Alison worked with the multidisciplinary team in the Mulberry unit where Ross Baker and McLaurin and I visited them in Tayside, and it's a 25-bed acute mental health inpatient unit where they explored the use of the framework to improve their safety in relation to medication management. Morag is a podiatrist and has worked at NHS Tayside since 1989. She spent 2 years working as the improvement advisor on the Older People in Acute Care Collaborative and has developed her quality improvement knowledge and skills over 9 years. In 2013, Morag was appointed the Patient Safety Development Manager for NHS Tayside, and Alison and Morag are going to describe their experience in implementing the Vincent Framework at the front line. Following Alison Morag, Dr. Jonathan Kirk will speak to us about key learnings relative to the frontline implementation of the framework in Scotland. Before moving to Orkney, Dr. Kirk was the Associate Medical Director of NHS Borders and was directly involved in testing the framework in the Borders Trust. He's now the Associate Director, Medical Director, and is practicing remote and rural general practitioner. He's a Scottish Patient Safety Program Fellow and the National Clinical Lead for the Measurement and Monitoring of Safety Program. And finally, Ross Baker from the Institute for Health Policy Management and Evaluation will tell us how he believes the framework can be used within the Canadian healthcare context. We are going to ask you to enter your questions in the chat box or the Q&A box, and we will address the questions after we have finished the speakers. Now, before we turn this over to the speakers, we're just interested in where you're all from. Could you take your pointer and indicate on the map of Canada where you're calling in from? If you're calling in from abroad, click outside the map in the general direction where you are. Anne McLaurin's just indicated she's from Prince Edward Island. So we only see, oh, Joe Thompson, I see you.
Alex, you may have to grant privileges to participants to use the pointers.
Here they come. Oh, there, thank you. Great, we've got good representation across the country. Here's another activity I'd like you to do is to tell us who's using the framework. Again, with your pointer, indicate where you sit on this continuum of your experience with the Vincent Framework. You haven't had a chance to put the framework into action. you're starting to plan the implementation of the framework, or you've already started your journey. So that's terrific. So we've got a few people that are planning, nobody that's started, and quite a few people that they just are getting off the board now. This is a perfect opportunity for you. So that brings me to introducing Joe Thompson, who will speak to us about the experience of how Scotland came to be involved in the measuring and monitoring of safety framework. Joe.
That's great. Thanks for that invitation, Virginia. So we're just going to talk to you about how we've used the framework in Scotland. So good morning or afternoon where you are. It's just after 5 o'clock here in Edinburgh. As Virginia said, my name's Jo Thompson. I'm a Senior Programme Manager within Healthcare Improvement Scotland and the lead for the Measurement and Monitoring of Safety Programme in Scotland. Healthcare Improvement Scotland is a national improvement agency, so we work right across Scotland, and we also have functions for evidence, scrutiny and assurance. So NHS Scotland, Scotland is a very small country in comparison to Canada. We have just over 5 million population, and our land mass is just over 80,000 kilometres squared, which I know Canada is the second biggest country in the world at over 9 million kilometres squared. So we're a small country, and I think that also helps us sometimes in our approaches to improvement. And so Healthcare Improvement Scotland works across Scotland, and for this work we've been working with 2 boards, and we'll explain the approach that we've taken to test the framework in Scotland. We're delighted to be able to share what we've learned so far, and we hope that it's helpful as you start on your journey to use the framework. You might already know that Scotland already had an interest in national improvement programmes. So we've had our Scottish Patient Safety Programme since 2008 and now have national improvement programmes in the early years in education and schools. And for us, that was really important and helpful grounding for us when we introduced the framework. And it's not to say that you can't introduce it if you don't have that background, but it absolutely helped accelerate our use of the framework. So you'll know that the framework was published by the Health Foundation in 2013, and we were an organisation that was invited to bid for some Health Foundation funding, along with Tayside and Borders, to formally test the framework. And the Health Foundation were really keen for us to pull it apart, see what worked, see what didn't work, and capture our learning as we went. So in January 2014, we started an 18-month formal programme of testing with others across the UK. And our learning and our testing continues to this day. And this is a great opportunity, I think, for us to be able to learn together and to share that as we all progress on this. So along with Healthcare Improvement Scotland, there were 3 other regional improvement organisations across the UK who supported testing in their regions. So the Advancing Quality Alliance and HALO, they're on the left of the screen, are in the northwest of England, and Yorkshire and Humber Improvement Academy on the east. And each of these organisations supported testing in 2 test sites. And this ranged from a range of healthcare settings, including mental health services, which you'll hear more about shortly, inpatient high security settings, across pathways such as sepsis and frailty, and in an ambulance trust as well, to name just a few. And today, to give you some context of where we all are, after it was great to see the map of Canada and where so many of you are. Jonathan's up there in the north in Orkney, and Morag and Alison there are in Dundee, and I'm in Edinburgh. So as I say, we supported our testing in NHS Tayside and NHS Borders, and in Borders they decided to test the framework in their frailty pathway at the point of admission to hospital acute care, and also in their ward-to-board transactions, so from a ward interaction across a hospital and through their governance committees. You'll hear more about the Tayside testing in a moment from Alison and Morag, but I think it's important to say that, as with all improvement work, it was, in hindsight, and we all know this anyway, it's important to have a clear aim. It's important to understand our theory of change, to think about not trying to solve world hunger, but have a focused aim and a focused scope for this work, and to consider how to measure the impact of the work as you go. And I think it's fair to say that we probably did some of these things better than others. So just before I hand over to Morag and Alison, I wanted to signpost you to some further information. We have a website for the programme and for the framework, so howsafeisOurcare.com. And on there you'll find many videos explaining our testing and our thoughts around that. We have monthly calls, which it's great that some colleagues in Canada have already joined some of them, and we're continuing to build a community of people who are interested in using the framework. The next one is on the 15th of March. We're in the process of developing an interactive PDF which will have case studies, resources, templates, and helpful information that we hope will be useful to people who are starting to use the framework at the start of the journey. And of course we have a hashtag on Twitter as well if you want to join in the conversations there. So as I said, we would love to learn with you, and it's great to be able to talk to you at the start of a journey of using the framework. We're still learning about it, and we're keen to continue to share that as we progress with further testing over the next 12 months and as you start your journey. So please do keep in touch with us, and we're happy to share more information and also to hear how you're getting on. So just as a handover to Morag and Alison, that's Tayside circled on the map there where they are this afternoon. They hosted some of your colleagues last year that Virginia spoke of, and there they are in Dundee. And they're going to explain in more detail how they actually tested the framework and some of their reflections.
Thank you, Jo. And thank you for inviting us along to speak to you this afternoon. My name is Morag McRae, as you've heard, and I'm the Patient Safety Development Manager in NHS Tayside. We really welcome this opportunity, as we say, to have a wee blether with you this afternoon and tell you some of our stories and our experiences of using the framework. I was going to start with a joke about Neil Prentice, who's our Associate Medical Director, not being with us today because he was on the golf course, but actually that's not true. Neil has clinical commitments. But he wanted to send his best wishes to you all in Canada. And I'd like to say that Neil's leadership support has been absolutely pivotal throughout our journey of using the framework, and hopefully he'll have the opportunity maybe to speak to you at another time to go into more of the organisational detail around the use of the framework for us in Tayside. So prior to the start of the project here in Tayside, we'd already taken a keen interest in the content and the learning from the Monitoring and Measurement of Safety report when it was published by the Health Foundation in 2013. We were part of some work that the Health Foundation had undertaken with Sarah Garrett around road testing the framework. So it had already been widely discussed within our organisation at all levels, and it had been decided that we were going to further investigate how we could use the framework to better understand and reflect on our current measurement and monitoring systems within the board. So when the opportunity then presented itself to become part of a national programme of testing, we jumped at the chance and we were really keen to be involved in that. So this is the Susan Carnegie Centre where the Mulberry unit is based, and as Virginia said, it's a 25-bed adult mixed-sex unit. And as you could see from that first slide, it's in a very semi-rural area within NHS Tayside. And initially the focus of our work was to work with a multidisciplinary team from across community and inpatient mental health services, so to work across the interfaces of those services. However, we quickly realised that we needed to segment that down. It was too big a focus, and as Jo said, we needed to keep it manageable. And so we focused initially on the inpatient unit, which was the Mulberry unit. The team in the unit had already been actively involved in improvement work, and so we felt they were in a good place to take the framework and start to draw out the opportunities for testing and evaluating its applicability. And this is one of our key learning points, was that it was actually an advantage to have an understanding of QI methodology. So our aim was to work with the team to begin to identify gaps in their safety monitoring and develop then a realistic set of measures for the team. But we also wanted to provide the team with opportunities for them to think about the implications for their own roles in making safety everyone's business. In the early stages, we used the framework to map out all the routinely collected measures that the clinical team collected. And what that did was it reinforced our theory about the burden of data collection on clinical teams, which is something we've discussed quite a lot, not just locally in Tayside, but nationally in Scotland. And we were certainly collecting data that wasn't really being used to make any improvements in care. Now, this is a really useful exercise doing this mapping, but actually it felt like all we were doing was recategorising our data into headings. So it was useful in a sense, as it helped us to identify where our gaps were, and there was no surprise to learn, and this may be something that you'll find as well, is that much of the data that we collected sat within the past harm and reliability dimensions. So we went back and forward quite a bit, thinking sometimes did a particular measure sit within a particular dimension, and actually we probably spent too much time thinking that. So all of that was fine, and we felt like we'd had a bit of a starting point when we mapped the measures. But actually for the clinical team, they were left scratching their heads a bit and thinking, yes, that's great, but what does that actually mean as we start to move on? And what does that mean in terms of improvements for patients and for staff? So we seemed in the first couple of months to talk a lot and to try and get our heads around the concept of the framework. And we had a number of ideas. And as we became more familiar with the framework, our thinking definitely started to evolve, and we started to move away from that large-scale mapping. And two things were happening at that time, really. One was that we were building our project team. We were developing our theory of change, and as Jo said, that was really important that we had that. And we developed resources focused around a project room within that unit, which we used to engage the clinical team with the project. We spent quite a bit of time taking the team through the framework and the concepts within the framework. And we reviewed the safety priorities with the team. We focused on the data that we did have, which was around past harm and reliability. And we spent a lot of time collecting qualitative data from staff surveys, feedback, patient surveys, focus groups and patient stories, and you'll hear a bit more about that in a film that we're going to show you. And that helped us to provide a much richer picture of what quality and safety meant, not only to the patients, but to the staff as well. And it was really after much of those discussions and looking at that data that we decided to really focus down onto two particular work streams. And those were safety planning and medicine safety. And it was really then that we started to get a bit of traction with using the framework within the clinical team. I'm going to pass the ball back to Alex so we can share the film with you.
for those who do not have speakers on your computers, you're not going to be able to hear this this video, but we will send you the, we'll put the link in the chat box, and you'll be able to see it when you get this whole slide deck.
Data. We'll also look at the narrative, because we feel that the story behind the data
Back to you, Morag.
Okay, thank you, Virginia. Hopefully most of you will have been able to hear that film because it really describes very nicely what Alison, I'm going to pass over to Alison now, and describe in a bit more detail the work particularly around the medication omissions.
Good afternoon, everybody. Thank you very much for allowing me the opportunity to speak to you all over there in Canada. As it's been clear, hopefully through Joe's conversation with you and Morag's and James on the film there, it became evident that some of the most important work we were doing was through the engagement and involvement of our stakeholders, and how this could lead to the co-creation of safety within not only our pilot unit, but within the wider organisation. It's always been important to us to ensure that patients and carers are active participants, not only in their own care, but also when we're developing improvements within the service. To allow us to get more of the patient feedback, we actually had a really good opportunity because we had a peer support worker who worked within the Mulberry unit, and she was very proactive in seeking the patient experiences and the patient stories throughout the whole kind of programme as we were piloting it. What I've been tasked with today is actually giving you a very practical example of how we applied the framework within the Mulberry unit. So in the next slide, you'll see that, as we said before, we started off quite big, thinking, you know, we can do this at all the multidisciplinary kind of interfaces with the community services within patients, but very quickly, and also following a kind of conversation with Charles Vincent, that really it came down to just kind of looking at it in a much more focused kind of way. So we ended up with two clear work streams, one of them being safety planning and the other one being safety medicines, and looking at how we can make medicines safer. What we then did was actually put safer medicines at the middle of the framework, and I think if I was to give you any piece of advice, this is probably the best way to do it, is actually put your subject in the middle of the framework and actually just work around the whole framework. It's really important to look at it as a whole framework and not just focus on kind of one domain at a time. You really need to keep the whole picture kind of in mind throughout your improvement plan. So what we did with the safer medicines was actually just, as a whole team, looked at kind of what is the past harm that's actually happened in terms of, you know, medicine errors, mapped that out against the framework, and then started working our way around. So we had a variety of things looking at medication reconciliation on admission, on discharge, on transfer, looked at the kind of current processes, the current data, and how we were actually applying that day to day. And it very quickly became apparent that even that was too big an actual thing to work on. So what we then looked at was actually just the medication errors, and in particular the omissions of medication. And there was, I think, probably three reasons why we actually chose that. The Mulberry unit was purpose-built back in 2011, and sadly the only bit that was really bad of the Mulberry unit is the drug dispensary, which is a very small room, it's very cramped, it doesn't have any windows, and you can imagine a small room full of two medicine trolleys and all the kind of drug cabinets around the walls, with two members of staff trying to dispense medication in a safe manner. So that was one of the issues for us, and obviously the feedback we had from staff about that was that it was very cramped. They felt very much under pressure when they were dispensing medication to patients, and that there was absolutely no time to discuss individually with patients any of their own queries that they had about their medicine regime. And finally, the third thing was actually the feedback from patients. As you saw from the film there were people who were saying that they queued for medication. Now, not because we encouraged them to queue, but it just naturally happened, and therefore it meant that there was a definite lack of privacy. There was a kind of pressure point there as well. So these three things kind of highlighted to us we should possibly look at the medication omissions as our focused piece of improvement work. What we then looked at was, again, taking the framework as a team and just looking at all the bits of the framework. What was the harm that was happening? The fact that we were trying to have a reliable process for approximately 20 staff nurses, all doing it in a very different kind of manner. The fact that they were getting interruptions, the fact that they were losing concentration led to the increased errors. Moving round the framework, we felt that that obviously meant the medication round was not safe, and therefore we needed to do something about it. And moving further down to the anticipation and preparedness, because we weren't able to kind of respond to the patient's request straight away, we really weren't anticipating how they were feeling, what they were thinking, and it really wasn't very person-centred at all. And there was really no kind of learning opportunities for anybody in the kind of picture, hopefully, that I've painted for you. So what we agreed to do was, as a team, we kind of thrashed out how we were going to actually make the improvement. And all the way through it, we were very conscious that you have to think about, right, what are you going to measure? How are you going to monitor whether this is actually improving or not? So going back around the framework again, what we agreed to do was just carry on doing the drug round the way that we were doing it, but look at the kind of number of, how long did the medication round actually take? How many interruptions were we getting? What was the number of admissions that we were actually having within the unit? And continued to monitor the kind of patient experience and the staff experience. Again, the patient experience was through discussions with the peer support worker. And that led us to establish a set of baseline measures and a way of monitoring our activities. So how did we go about making the change? The main bit was really spending time with the staff, helping them to understand the kind of concept of the framework. They didn't have to necessarily understand everything to its finest detail, but it was really just introducing the concept to them and how we were going to use that to improve the medication round. So there was lots of team discussion at the start with the multidisciplinary team. The medics were involved, the staff nurses were involved, the peer support worker was involved, and also some of the more peripheral staff, the domestics, the occupational therapy staff, some of the people who just kind of came in and out of the ward. And what we decided was we would actually have to be much better organised in terms of the drug trolleys, and the kind of consensus came that we would actually take the drug trolleys out of this tiny drug dispensary and go to the individual bedrooms within the unit. So what we did was organise the trolleys so that 2 people went out every morning with the trolleys to the bedrooms and actually dispensed the medication that way. In terms of the reliability, everybody had to pretty much do it the same way, so 2 staff always went, they were always identified who was going out. It allowed them to spend time with the patient, going over, any queries that they had about their medication, about just general conversation about how they were feeling today, what was going on for them today. So as you move around the framework, looking at sensitivity to operations, it made the staff feel a bit more safe, and it also, the feedback was it made the patients feel more safe at that time because they were actually seeing, was the person distressed, had they slept well that night, what did they have planned in terms of activities for that day, and it just allowed a much more kind of person-centred approach, albeit that it was around the medication round. Again, moving around the framework, that allowed us to be much more prepared for what might happen during the rest of that shift. So, for example, if you did have a very distressed patient, that could be flagged up at the end of the drug round saying, they haven't slept well last night, they're feeling quite demotivated this morning, they're feeling very anxious, and that allowed then the delegation of staff throughout that shift, to be working with that patient if that was indicated. Also allowed you to discuss with the patients what kind of activities were on in the unit that day, what they might be interested to take part in, rather than just focusing on kind of medication as being, the one and only kind of treatment option. One of the interesting things as you moved around to the integration and learning part of the framework was that of the 2 people who were going round in the trolleys, there was actually, one of them was a healthcare assistant who would be an unqualified person, and one was obviously the qualified practitioner. And what the healthcare assistants fed back to us was that they actually learned a lot about the medications that the patients were receiving, and that they felt that that was, something that they really hadn't had the opportunity to do before that. And also, as I say, the patients then learned more about their own kind of medication. So that's really the focus of the work. That was the main kind of things that we did in terms of how we did it. What we've got on our slide is an infograph that was done, and it really just describes the journey that we took. There's parts of it where we had to kind of stop, take stock, why was the medication errors maybe rising again, what was happening in the ward at that time. And I think in the past we might have kind of given up at that point and thought, it's not working, we're not going to do it. But it actually forced us to go back to the domains of the framework and look at, well, why is this not working? And it very definitely gave us the impression that it was because the ward had become more acute at that point, and we had to be mindful of that in the future and how we organise things in the future. So as I say, the infograph is on the slide at the moment, and there is a link to that which hopefully can give you a wee bit more information about that. What we did end up managing to do was demonstrate a reduction in the medication omissions and improve the engagement with the safety briefings on the ward, and also generally just with the patients on the ward. There was routine involvement of the patients and the consultant, just about how we were developing the patient safety culture across the unit. All the data that we were collecting was made very visible to the staff and the patients. There were run charts, there was patient stories, there was feedback displayed around the ward, and it did prompt questioning, you know, via the peer support worker, via some of the staff nurses, in terms of, you know, what we were doing to improve just the overall safety culture within the unit. So hopefully that's given you a bit of a flavour of just one way that you can use it. As I say, it sounds simple now when I describe it, but at the time, you know, the framework really encouraged us to think not just about what happened in the past, but how are you actually going to plan things for the future. So our next slide is just really asking you to kind of reflect on what you've heard from our story. I think we're most proud of the engagement and enthusiasm for this work that we got at all levels of our organisation. And we've engaged the local team with the framework, and we feel that we've also got the full support of the senior management within our NHS board. I think whilst you're doing the project, it's very important to kind of capture your learning, and we captured it in a variety of ways, partly because that was what the Health Foundation wanted us to do as well. But within our project room, we had one wall devoted to each of the work streams. We would display the data, the information there, and any kind of patient stories that we had. We kept a reflective comments book which we encourage staff to use, and we've got a storybook which captures the kind of timeline of our project throughout all the stages, the good, the bad and the ugly. We also had some sessions with staff to capture their key messages, primarily asking the question, what difference has the framework made to your improvement activity? I think some final thoughts we would like to share. We believe that the framework is very flexible and adaptable. It can be used at ward level, service level, and we believe at board level. Our multidisciplinary team interpreted the concepts within the framework in a way that supported them to have a more holistic view of safety, and the application of the framework to particular safety issues, for example, the medicines emissions, was able to help us focus and prioritise just one particular area. I think it also helped us to understand what's important to patients. By asking the right questions and listening to them, we were able to broaden our understanding of what being safe means to them, and at times it was different to what we felt was safe. The sensitivity to operations, anticipation and preparedness, and the integration and learning domains lend themselves to teams being able to do this and fundamentally provide a person-centred approach. I think key to all this was the good leadership that was required to support the team. It was very much the team's project. It wasn't a project that was kind of put upon them. It was very much they owned the project. They were in charge of the project. They had control of the project. And I think one of the key aspects for us is look out for some of the kind of unexpected benefits that come with applying the improvement work. Obviously, taking the drug trolley to the patient's rooms actually meant then that the corridor was able to be cleaned by the domestics in a much more safe manner because people weren't queuing down the corridor. We hadn't really thought of that before we actually applied the project. And also, because we were encouraging patients about the activities that were on the ward, you then got more people actually attending things like the occupational therapy groups. So overall, a very positive experience, and I'll hand you back to Morag just for the final kind of reflections.
Thanks, Alison. So I'm not going to go into this slide in too much detail, but what I wanted to show was that we are applying the framework locally, as Alison's described, to particular interventions, but we're also using the framework organisationally as well. So the work that's happening at the local level with the clinical teams is helping to influence what we're discussing through our clinical governance review processes. And I spoke earlier on about supporting the development of a realistic set of measures, and that's what I'm showing here, that this is what we're starting to do for mental health services as a result of this work. And And then just finally to say, we're using the framework in a way that we believe brings benefits to patients and staff. We've certainly moved away from focusing solely on past harm and reliability, and more on some of the softer stuff around the behaviours, the relationships and the culture within a service. And that's through the other dimensions, through the sensitivity to operation, anticipation and preparedness and integration and learning definitely gives you the opportunity to do that. So I suppose it's really over to you now to think about how you could apply the framework to your projects. And I think that's handing back to you now, Virginia. Thank you very much.
Thanks, Morag and Alison. That was great. Our next speaker will be Dr. Jonathan Kirk, and he will talk to us about the key learnings at the Frontline when implementing the Vincent Framework in Scotland. Over to you, Jonathan. Can you give Jonathan the ball, Alex?
So thank you very much for having me. It's quite an amazing experience to be speaking across the world from Orkney, which is a beautiful place where it's just started snowing. So in terms of why I became involved in this work, really, it was, at the time I was Associate Medical Director down in the Borders and trying to head up a clinical board and also head up a senior management team for the hospital, covering both the hospital and primary care. And I was very conscious that there was certainly no shortage of ideas coming at me about how I might go about improving things. In fact, in many ways, I felt utterly overwhelmed by those ideas and really lacked, I think, any real understanding of how on earth one would go about executing those ideas. So fundamentally for me, the framework comes down to the problem we've got is that not every change that we make results in an improvement. And it didn't take me long to realize that, frankly, we didn't really have the wherewithal to understand which changes resulted in improvement and which ones didn't. And therefore, oftentimes I kind of was left with the notion that maybe we were better off not doing anything at all, rather than introducing new things which we would have no idea whether they were working or not. And that situation really is one, as a clinician, is really no different to the situations I find every day in terms of trying to decide what to do for my patients. And as a doctor, when I read this framework, I saw something that resonated very clearly with me, and I think there is a key message in there which I hopefully will try and get across to you through this next 10 minutes. So certainly in Scotland, we've become prolific almost in describing what is ideal. The guidelines that come out almost daily and frameworks and telling us what the benchmark is for the perfect world. But unfortunately, in reality, if we fail to consider what is real in equal measure to what is ideal, it often leaves us with a deficiency between the two. And it often feels as though the gap, if anything, is getting wider in terms of what is supposed to happen versus what we all know actually happens on the ground. So the fundamental part of that really is it comes down to the way we use data. And I'm sure Charles will have talked to you in your first session about the problems of looking primarily at past harm. And the fact is that we are geared up mainly in reality to look at what's gone wrong. I don't know if in Canada you have a program called Catchphrase, but this next slide is supposed to depict the everyday reality of what we would call in the UK flying by the seat of the pants. And the problem that we have really is that when we just look at past harm, in many ways we're not so much measuring safe care, but rather how well we practice unsafe care. If you like, how often we get away with practicing unsafely. And to give you to think of an analogy for that, I guess if I was to put a blindfold on and walk across a fairly busy road. I might be lucky and make it to the other side. However, it's inevitable that if I keep doing that, sooner or later I'm going to come a cropper. And in many ways, that is what we're measuring when we're looking primarily at past harm. We're measuring how often we get away with it. And certainly as clinicians, we're conditioned. We've been trained almost to cope in adversity. So the framework really does open our eyes and extend our thinking beyond looking at how well we get away with things to actually looking at preparing the conditions to actually be safe in the first place. So that brings us on to what safe actually is. And the problem we have really, traditionally, we've had a fairly narrow definition of what safe is. And ultimately, what we consider safe to be and how we define safety determines what's in and what's out when we decide to sit down and talk about safety. And through the framework, what you find, or what we found, is that it broadens the conversation. So different aspects of practice that previously weren't considered when we were talking about safety become part of the same conversation. So what that does for us is create an alignment between some of the different quality ambitions. In the UK, certainly, I would imagine, I'm sure it's the same in Canada, we focus very much on our strategies and our clinical strategy, our national strategy has been largely fallen from the Institute of Medicine's dimensions of quality. The problem being then that we developed a program structure that led us to consider person-centeredness and to consider effectiveness and to consider quality as different parts of the conversation from safety. What the framework can do is help to bring those conversations back into the same room so that we consider all these aspects together, and that helps us to untie some of the operational knots that we've tied ourselves in considering these things separately. Another reflection from the framework, and again, it speaks about how we've perhaps come to focus our efforts in multiple different ways, is the difference between collaboration and cooperation. And again, the framework brings that to the fore by helping us to understand the difference. And I think from my understanding now is that cooperation is when you've got, if you like, lots of people agreeing to sit in the same room, but not necessarily speaking the same language. What the framework can offer us is a way to change that cooperation into true collaboration, which for me is people sitting in the same room and actually speaking the same language as well. And there's a vast, vast difference between those two things. So ultimately what we're talking about here, and anyone that wants to be involved in the framework or wants to use the framework, we're talking about decision making. And how do we make sure that the decisions that we make are as likely to be good ones as possible? And as in any walk of life, in order to make good decisions, you have to have a complete set of information. And what the framework does by helping us to look not only at the past, but at the present and at the future, looking at what things actually we did agree to be consistent at, and looking at how we share that information with each other so everybody knows what's going on in real time. Those are the things we need to do if we want to really get a complete picture on which to base our decisions. I don't think the framework for me is, although it seems complex, in its essence is delightfully simple. And the reason it's delightfully simple, if you sit down and think about it, is it reflects the way we make decisions in everyday life. If, for example, I was choosing to do a road trip down the mainland Scotland, I probably wouldn't just get in the car and drive off. I would probably check to make sure that there was water in the windscreen wiper washer. I would check the dashboard to make sure that there was oil in the engine. I maybe would phone ahead to let somebody know that I was setting off. I would check the weather forecast to make sure that there was no snow on the road. I would make sure I had the right clothes in the car. I would check the tires, maybe put a shovel in the back if it's snowing. So all of these pieces of information I would gather together so that I could make a fully informed decision based not just on what happened to me last time I made the trip, but what might happen in the future, so that that decision has the most possible chance of being a good one. And that, to me, is the way we make decisions all the time. It's the same way I make decisions when I see a patient. I get the patient in the room, I build some kind of relationship. I take a history which involves the past, but also the presenting complaint, and then I seek to supplement that information with investigations and a clinical examination. This is the way we make decisions every day of our lives in every setting. And the framework really is just bringing that logic to the way we make operational decisions at all different levels. And the important thing about that is that's your hook. So people, one of the observations is that's been made across the world when looking at the framework is that it seems to resonate well with people. And the reason I believe it resonates well with people is because it aligns very closely to the common sense way that we learn. It's the way we've done things since we were small. It's not just at work, it's in our personal lives, it's in our professional lives as well. So in essence, what the framework does is it helps us to gain that full set of information which tips the scales in favor of the decisions we make being good ones. So measurement really is the process of gathering that full set of information. And we can't monitor effectively until we measure. So monitoring then comes from, well, okay, how do we maintain that set of information and maintain that knowledge of what's going on over time? So in terms of the framework, it can be at every level: organizational, group, individual clinician, individual problem. I would encourage you to try the framework, test the framework at every single level. And essentially, take-home message, what we're doing here is we're looking at moving away from simply commentating on the absence of harm to establishing the presence of conditions that give rise to safety. Two different things. And it's all about execution. So how can we recognize the multiple confounding factors that seek to stand in the way of us making wise decisions, and recognize those operational deficiencies and gaps that help to prevent us from executing effectively. So thanks for having me, and I think we're passing on to Ross.
Yes, thanks very much, Jonathan. Ross, you've got a few minutes to just speak to everybody about what this all means to Canada, and maybe mention our evaluation study. You got to unmute him.
Thanks, Virginia, and thanks to all our Scottish presenters for their very clear presentation of the materials and the experience they had working with the framework. We were quite impressed when we visited them in the fall with this experience and wanted to share that. I'm just going to say a few things because I want to leave a little time for questions. One is that the framework is really very appealing in terms of its range of issues and this ability to bring the focus away from past harm alone into an understanding of current operations and understanding how we can learn how to integrate safety into daily work, and to make all staff aware of their practices and their ability to create safer work environments. At the same time, what we saw was that many units struggled to do this, and I think it's partly the nature of the framework, but it's also partly about the tyranny of daily work and the need for support to help to change the conversations that need to occur in order to do this in a comprehensive way. So that led us to this thinking that we really need to adopt the same approach that they've been doing in the UK, which is to learn together across a series of teams and organizations who are willing to try this out in different clinical environments and to just understand how to move from past harm to current operations, anticipation, preparedness, and learning. And we want to do this taking advantage of the expertise that you've heard today and you heard earlier with Charles and others in developing and applying this framework. And so we're developing this project and inviting expressions of interest of people who want to take part in this in a collaboration that's organized by the Canadian Patient Safety Institute with a strong evaluation component to understand from the participants what works well, what requires additional effort, and how do we build this in a robust way to really help to refocus and integrate our thinking about safety into current work. So that's all I'm going to say, and Virginia, I'll open it up to questions.
Absolutely. Thank you, Ross. I wonder if you could enter your questions in the Q&A box, and we will watch for them and or in the chat box, and we will get our guests to answer them. And first question is, in the example shared by Morag, how did the existing limitation of the facility was solved using the framework? Morag?
Could I just ask Virginia for a bit of clarity about the question? How did the existing limitation of the facility was solved using the framework?
So it relates to pharmacy. Maybe, Alex, can you maybe unmute?
Space was an issue. I think maybe what you're asking there was how did the framework help to solve the issue of the limited space?
Yeah.
Yeah, so I'll hand over to Alison again, but that was really around one of the improvements that was then identified because we'd used the framework to help us understand what some of the challenges were.
I'm not sure it would add much to what Morag has actually said. I mean, we didn't end up with a different drug dispensary. We just really had to work with what we had. What the outcome of the project was that we used it in a very different way and actually only stored the medication within that room, but did the dispensing out in the unit, as I said, in the individual people's bedrooms.
Thanks, Alison. When you described it to us in Scotland, it was very clear because you'd also described in the dispensary, you noticed that the nurses had different methods for signing off their drugs, and that was a big aha moment. And
yeah, that was part of us getting a reliable process. So yeah, you had some staff who would sign it off at the point they dispensed it. There was others that would sign it off once the patient had swallowed it. So it was really looking at developing an absolutely reliable process across the 20 staff nurses who worked within the Mulberry unit.
So Alison, if you just glance at this next question from Michelle, who says, how many patients were on the units compared to ratio of staff? In her workplace, registered staff, unregistered staff for 28 patients, and 3 personal support workers, healthcare aides. What's your ratio there?
We would routinely, for the 25 patients, we would routinely have had 6 staff on an early shift, 6 staff on a late shift, and 5 staff overnight. And they would be most often 2 qualified staff and 4 unqualified healthcare assistant staff.
Thanks.
What we would have in addition to that would be our kind of peripatetic staff, so occupational therapy, physio, that kind of, peer support workers coming in. But generally it would be 6, 6 and 5, and 2 of them on each shift would be a qualified nurse.
I'm going to skip Danny for 1 second. We'll get back to you, Danny. Kirby Peterson is asking, we've heard about the importance of scoping the framework down to a manageable issue. Does this inhibit the implementation? Does this inhibit the implementation of the framework on a board or service level? Jonathan, maybe you could answer that one.
Yeah, I mean, the simple answer to that is no. And I think what I would urge really is first of all, you need to define the problem, and the problem that you're trying to solve will be different whatever level you're considering the framework at, whether that's a group, whether it's an individual, patient, whether it's an individual aspect of safety, if you first define the problem and work out what it is that you're trying to solve, you then can use the framework to work out the set of information you need to have a good understanding of what that problem is and where the barriers are to effective solving of that problem. The framework helps to surface all the issues and discover the unknown unknowns, because very often the barriers to improvement aren't where you expected they would be, and the reason you're not managing to solve the problem is because you're not asking the right questions. And that is as relevant at any level of the organization. So any particular unit that has a problem to solve can use the framework to solve that problem in tandem.
Okay, we're really at the end of our time. I'm asking Alex to post our poll. If you could all just take a minute to answer the 5 questions on the poll, that would be very helpful. And in the meantime, I will ask you to answer Danny Curry's question about what is the current level of engagement of staff and patients in improving safety. And I don't know whether that might be Joe.
In terms of engaging staff, I think we do have
safety, yeah.
I mean, we have good engagement already with some of the national programs, and Morag might be able to say a little more about that, as we've got pockets of improvement work nationally for the Scottish Patient Safety Programme. So, as I said, we do have that baseline that we started with, which I think was a real benefit to us, but Morag might want to say a bit more about that.
Yeah, well, locally with the clinical team that we worked with, I would say there was a high level of engagement with improving patient safety, and particularly using the framework. And we used things like climate surveys to support us with that, so we got regular feedback from them, and from patients as well. So this is very much, the whole project was very much about the co-creation of safety with patients and staff right at the heart of that. I would say in more broader terms in our organisation, we've just come from an event at lunchtime here today where we were sharing with our executives and non-executives a lot of the patient safety work that's going on across our organisation, and that was then hearing about that from frontline clinical teams. And all of those pieces of work have patient involvement in them as well. So I would say our level of engagement is good. There's always room for improvement, but I would say we have good level of engagement, yeah.
So thank you very much. On behalf of the Canadian Patient Safety Institute, we want to thank you all, our Scottish colleagues from whom we have learned so much, and for your generosity and sharing your time and knowledge. I just want to announce that we have another call that will be booked in April. It will be on how your board can use the Measuring and Monitoring for Safety framework, and we will send out the date and time as soon as it's confirmed. Thank you, everyone. If you want to know more about the evaluation study, you can contact either myself, Virginia Flintoft, or Anne McLaurin. You can see that on the screen right now. Thanks again.
Thank you.
Thank you.
Thank you.